Hello, this is Heart Rhythm TV, and I'm Jody Hurwitz, President-elect of Heart Rhythm Society. This is Advocacy in Action. Today, we have Dr. Amit Shanker, who's Chair of Cardiovascular Medicine at St. Lawrence Health System. He's going to help us talk a little bit about the Health Policy Committee and the task force. He actually had been on the Health Policy Committee from 2009 through 2013 and has been back on for the last 2 years. And has a lot of good insight into a lot of what's going on. So I thought maybe we would start today with talking a little bit about what the Health Policy RAC Committee is, and especially how it differs from the CMS Strategic Task Force that has just been implemented, of which you are also a member. Welcome.
Well, again, thank you for having me on the episode today. So I think, you do bring up, I think it's important to make a delineation between the health policy or the HPRAC and its role in parallel with the task force that was just recently set up. So the HPRAC, or the Health Policy Reimbursement Regulatory Affairs Committee, has been around for more than 15 plus years. And really the scope of the committee has been traditionally to oversee reimbursement regulatory for EP-related procedures, safety alerts, and also a great deal of advocacy. And that's been something that's been always on our radar since, I would say, early 2000s, and certainly since 2009, since we got a seat at the table at the House of Delegates with the American Medical Association. And that was actually the introduction to our getting in with the ablation codes. One of the reasons that we decided to pursue a seat at the table at the AMA House of Delegates was because up until 2009, we were largely doing a lot of our activities through ACC, and we didn't really have any direct seat at the table. And it's not that they weren't advocating for us, they were, but they had a lot of coals in the fire. So, in the late 2000, around 2010, Medicare actually approached us and requested that we simplify the code set further. And actually we pushed back and we made it more granular, introducing the AF ablation code, because we argued that there were inherent complexities within different types of ablations that were being performed. And we had a very favorable valuation with that. And now we fast forward 10 years, and of course, now we're dealing with what we're dealing with now. Could have happened 5 years earlier. Doesn't help the situation now. But, we did kind of, for the most part, coast under the radar, which is now promulgated with the task force that was recently set up. The task force, of course, is looking at the present, or where the puck currently is and where it's going. Whereas the HPRAC is been kind of the committee that's been there longitudinally, not just looking at where the puck is, where it's going, but it's also looking at where it's going to be. So the matters that we're dealing with right now at the task force that all of our members are dealing with are the cuts that have been implemented by Medicare, and how do we navigate those cuts, and potentially looking at where the puck is going. And what I mean by that is what's next on the chopping block. What is it going to be? Device codes. And actually 10 years ago, there was some noise about that with 33249, the ICD code, about possibly having to have that be revalued. There's a possibility that in the next few years that might be up for discussion, along with our current remote monitoring codes. So coming up with a preemptive strategy now to deal with what might be coming down the road will actually be another important task for the task force to discuss at this point.
So what I hear you saying is that the task force currently right now is dealing with the acute problems and the changes that we're going through, and helping us come up with a good positive direction to go. And the HPRAC committee is, like you said, more of a longitudinal committee where they're fighting the long fight, if you will. If they're looking at everything with an eye towards what's going to happen in the future, and how to stabilize a reimbursement, if you will, for electrophysiologists. I do think that you're absolutely right. I think we all need to be aware that a lot of these other codes, especially the device codes, are going to be revalued, and it's going to be very important that we all pay attention and work together, listen to you all, and have you aim us in the right direction.
Yeah, I think one of the, if there's a silver lining to this, it's made us realize that we need to strengthen even further our advocacy efforts. And, the issues that are going on in EP are not just limited to EP, because if you look at it from a higher level perspective, this started back in 2009 when ACA, the Affordable Care Act, was introduced. They were solely focusing on trying to shift payments into the outpatient setting with a medical home, and shifting it away from some of the higher RVU-based procedural specialties. So that's been in the works for years. And now with telemedicine expansion, and also the recent legislation with increasing reimbursement for E&M, Medicare is in a situation where they still have to focus on budget neutrality, and proceduralists like us are getting hit. Of course, we're on the extreme end of that bell curve, but we're not alone. So the question is going to be in the long term, where the puck will be, if you will, is working with a task force now to come up with some preemptive strategies and trying to, I think Andrew Cron put this quite well, how do you navigate in a no-win scenario? And he kind of alluded to a Star Trek movie that, and it was dealing with the Kobayashi Maru. But the way that you deal with it is by changing the rules of the game. So we have to figure out a way of how we can change the rules of the game. How do we maybe delink our remuneration with the current professional RVUs and maybe link it more towards facility remuneration? And or are there other technologies that are neural or neural based that involve ablation that indirectly involve arrhythmias or heart failure that we can start looking into that our electrophysiologists can perform? Because the reality is, it's the analogy I like using is, you buy a car, let's say any car 20 years ago, and it costs $20,000, and you have to sell it now. You want to get a new car traded, and you're not going to get a trade-in value of $20,000. That's just the way how market economics work. It's the way it works with products. It's the way it works with services. So as a community, as a specialty, we have to start figuring out other ways of reinventing ourselves, leveraging our core skill set, but maybe looking at electrophysiology in a different way, possibly outside of the heart, but with therapeutic modalities that affect arrhythmias or heart failure or stroke. So these are kind of larger overarching discussions that I think we're going to need to have, and having the task force provide guidance and support will be very important to that end.
Sounds actually exciting, kind of definitely thinking outside the box.
Yeah.
So we look forward to hearing more from you in the future. And want to thank you very much for coming on to the program, and look forward to working with you both with the HPRAC and the task force committee. Thanks again. And looking forward to, hopefully, I think within the next week, asking our CEO, Pat Blake, to come on and give some insights as well. So thank you all very much.
Thank you very much.